This week on the BackTable Podcast.
We're starting to see more and more indications outside of just our normal chemoembolization and radioembolization. I've become particularly fascinated with drug delivery. And so we have a clinical trial open right now where we're actually using the TriNav device and the drug that the company makes, nelitolimod, which is a TLR9 agonist, to treat HCC. And there's some interesting trials that came out looking at ocular melanoma as well as HCC and cholangio with both intrahepatic delivery of immunotherapy and systemic immunotherapy. And then I think we're going to start to see a lot more of this drug delivery coming out where more and more trials look at, intraarterial gemcitabine for pancreatic cancer, et cetera. So I think the future is very bright, and especially as we start to figure out how we can get more higher concentrations of drug very locally that you can't get physiologically, I think we're going to see, a huge benefit. And I think pressure is one of the ways we could do that.
This episode is brought to you by TriSalus Life Sciences. When it comes to treating complex liver cancer patients, precision matters. That's why many interventional radiologists are turning to the TriNav infusion system with its pressure-enabled drug delivery approach. Designed to improve the tumor-to-normal ratio, TriNav aims to deliver more therapy directly to the tumor while sparing healthy tissue. TriNav, a revolution in precision embolization. Learn more at trinavinfusion.com.
Today, we're going to be discussing the tumor microenvironment and specifically how that relates to pressure-enabled drug delivery with local-regional liver-directed therapies such as TACE Y90. To help me with this topic, I'm happy to welcome back to the show Zach Berman, vascular and interventional radiologist out of UCSD. For those of you with video, you may notice Zach is at the BackTable headquarters, the Brain Center, where we have a recording studio set up that turns out to be 5 minutes away from his house. Zach, thanks for coming back on the show.
Thanks for having me.
So, for those who may not know you, Zach, just like the icebreaker is, will you just tell us a little bit about your background and what your practice looks like?
Yeah, of course. So, like you said, I'm an interventional radiologist. I particularly specialize in hepatopancreatic biliary malignancies. That over time has slowly consumed my whole practice. It's been a really wild adventure with a lot of the research and new explorations. And in particularly, one of the areas I've been focusing on has been, this pressure-directed embolotherapy and the benefits it can possibly have. So I'm excited to talk about it today.
So as far as your practice goes, are you 100% clinical, or do you have a research day threaded in, or what does it look like?
My wife, who's also a researcher, always jokes that I'm 75% clinical and 75% research. But no, technically, I do procedures 4 days a week, procedures clinic 4 days a week, and I have a day to do research.
Yeah, I'm sure it's more than enough, right?
Yeah, exactly.
All right, so I think a lot of us know about the practice at UCSD, and I think anyone who's listened to the show probably knows a little bit about your practice. So before we get into the real meat of the topic, I wanted to back up and talk about the tumor microenvironment, and I thought that was worth laying some groundwork, so maybe some basic science groundwork, and I'll just kind of leave it to you to kind of explain the tumor microenvironment and how that relates to maybe liver-directed therapies.
Okay, great. So in order to keep this relatively simple, I'll probably lay off of a lot of the immunotherapy aspects of it and talk about the immune system, although that's a fascinating topic and probably someone way smarter than me is probably better to talk about it. So I'll predominantly focus on the vascular microenvironment and kind of the areas that we have limitations on delivering our drugs or our devices, or embolotherapies. When we look at a tumor on a CTA or an MRA or something like that, we see a very hypervascular tumor. It looks like there's just, big arteries going right to the tumor. Well, that is the truth, but it's also a little bit more complex than that because the processes that develop those big arteries are also simultaneously making it haphazard arteries, the development. So they're not necessarily following the normal big to small. Sometimes they're big, then small, then big again. They don't have the neural innervation, and they also don't have the smooth muscles around the arteries, which will become important, particularly as we start talking about mechanisms of pressure-directed embolotherapy. And then also, to some degree, the tumor itself has increased pressure just from the rapid cell division where it's not following the structure and scaffolding, pressing on those arteries that may prevent some of the drug getting in. So as we start to talk about, how these devices may help us get drugs or devices into the tumor, we're really thinking about that, the irregular arteries as well as the tumor itself and the effects on those arteries, if that makes sense.
So is it like an inflow and outflow problem? Like, I'm trying to just dumb it down for my own brain. Like the vasculature is different, so it's not really delivering blood or the things that are like going through the blood normally. And then also the tumor itself is just really, really dense, more dense than normal cellular tissue. And so there's like pressure that's inside the tumor that's pushing out or keeping things from coming in as easily.
Yeah, it's just, the simple forces we learned all about in med school, right? When you talk about oncotic and, the types of pressures, those are all competing factors where there's pressures pushing into the artery from the tumor, as well as pressures from inside the artery pushing out. And so one of the issues is you do get, the uncontrolled proliferation of these cells pressing in on the tumor vasculature. And then the second thing is you don't have normal vasculature going to these tumors. It's just, rapidly, quickly produced arteries that are, potentially not normal.
And this is like outside of the tumor microenvironment, but does it also have any bearing like on this topic, like tumors that are centrally necrotic, like once you get to a certain size and it's like the peripheral portion may be hypervascular, but you have like an internal kind of black hole as far as the enhancement goes?
It's probably even more pronounced in those scenarios, right? So as they're growing out, the densest part of the tumor is likely within the center of it. And it's also the area that has the least number of arteries. If it had a ton of arteries within it, it wouldn't be necrotic, right? It would still be viable cells. The struggle we have is we need to get drugs and devices like radiation or chemotherapy into that area of the tumor because there are some living cells. There may not be many, but if we don't kill all of the tumor, it will come back. And I think that's one of the challenges we have with a lot of our therapies is that in some scenarios, perfectly durable because we cannot kill every single tumor cell.
Got it. So that's like the groundwork for the tumor microenvironment. I want to know like the tumor microenvironment and like pressure-directed embolotherapy. Like how did this come onto your radar? Like when did you realize this was like maybe a problem worth solving or maybe a problem worth accounting for in your practice?
Yeah, so my genesis story is serendipitous, just I think like most people's in IRs is. So I trained at UCSD. I was part of their DR-IR fellowship. And so in my PGY 5 year, my first IR year, my mentor quickly became a gentleman by the name Steve Rose. And he was super involved in this pressure-directed space, did a lot of his research in the space and was very interested in it. My interest was, or at least my experience was mostly doing all these crazy experiments during procedures. We were measuring pressures in between each aliquot of surspheres that we were putting into the tumor. And I was just like, ugh, what are we doing? Like your other partners just do it in 2.5 seconds.
Sure.
And there was a little sense of, frustration because you're like, oh, I have to go round on the 20 other patients in the ward and consent the next patients. And am I going to get at home tonight at all? But the true benefit all kind of clicked with me the following year, my PGY 6 year, when we were doing a case in the middle of the night. And it was a ruptured HCC, 10, 12 centimeters. And we used onyx to do the embolization. And this is again with Steve Rose. And on one side of, it had two main feeding arteries. I'm going to say segment 7, segment 8. This is 2017, 2018. My memory is not perfect. We treated one with a balloon occlusion microcatheter, one of those arteries, and we treated the other one with just a traditional end hole catheter. And it was like night and day. Like you see a perfect cast of the arteries when we used the balloon. And, we effectively stopped the blood on the other side, but we really did not get that pretty cast of the onyx inside of the tumor. And so at that point I was like sold. I'm like, this is a much better way of embolizing. You don't have to use onyx, but if we were to use spheres or Y90, et cetera, that might be a better therapy because you're able to more homogeneously get it into the tumor. And then from there, I was hired on at UCSD. I was initially going to be doing vascular malformations, and I did for a couple years. We wrote a paper, multi-center, in 2020, kind of showing our experience. And from then, I was hooked. Luckily, right around the same time, too, the Surefire device was bought by the now TriSalus company and started having that come onto the market. And it was all serendipitously perfectly timed.
Okay, very nice. All right, so Genesis story check. Can we back up a little bit and talk about maybe for audience who may be naive to like what exactly catheters that we're talking about? Like what is pressure-directed embolotherapy, or sometimes you hear it called, pressure-enabled drug delivery?
Yeah. So the concept, increasing the pressure or changing the pressure, modifying the pressure, we think about it as a novel concept. It's actually not that novel at all. The first papers were coming out of Japan in 1991, where they were looking at it particularly for TACE in areas where you were also potentially perfusing the stomach. And so they used it to kind of protect the anti-reflux properties from the stomach. And there was a great paper out of Japan in the English literature, because I always joke I don't know how to read Japanese nor speak Japanese. But at least the first English one was in 1991, and then it was kind of lost to follow-up, I guess, for the next 10 years. And eventually, in the early 2000s, there was a resurgence, because not only were they starting to realize that you had the anti-reflux properties, but they were starting to see better lopiodal deposition into tumors. And so in Japan, around the mid-2000s to the early 2010s, there was a huge resurgence in conventional TACE, Irie et al. Being the first major publication that kind of looked at it, where they were saying not only are we getting the anti-reflux properties, but we're getting the better drug delivery, more of the lopiodal, more of the chemoembolic is ending up in the tumor, and less is ending up in the normal liver. And so that was kind of the start of balloon occlusion TACE, which then eventually came to Europe and then the US, and morphed into, how can we make this better than using these balloon catheters? And a company was started around that time looking at microvalves that you could deploy and take down. And the first microvalve instead of a balloon was the Surefire catheter. And that went through a number of iterations over the early 2010s through 2020 before it eventually was converted into the TriNav catheter, what it is today. The early devices were kind of a struggle to use, where you had to use a proprietary catheter that was really good at dissecting the celiac artery and spasming, and it really had its limitations. And luckily, engineering has improved significantly since then, and a lot of those issues have been mitigated. And now it's a much more easy-to-use device, but you still get the benefits of this kind of pressure-enabled drug delivery, which, as I'm sure we'll talk about, is not only increasing pressure, which is what we thought it was, but it's also the decreasing of pressure as well.
But specifically, and you mentioned it, talk about like the microvalve. Will you put a little bit more color on that? Exactly what's happening at the action portion of the catheter to give it the characteristics that make it kind of a different catheter. They're different than an in-hole, right?
Perfect. So let's start with the closest comparator and kind of first principles, right? So when you think about reducing pressure, stopping pressure, anti-reflux, the thing that most people think about is a balloon. Right? So you have a balloon microcatheter, and there's a whole bunch of different flavors of them on the market. You can imagine putting that into an artery, inflating it, you get the nice balloon shape where you're getting occlusion of the entire artery, and hypothetically flow becomes completely static at that point, right? There's no inflow coming into the artery. Now it's a little bit of a misnomer because there is still the vasovasorum, and you still do get some antegrade flow, but it really is as close to full stasis as you can imagine. The microvalve takes on that concept where you can, prevent the arterial flow, but you can actually change that dynamically. So in the current generations of the devices, the microvalve is up during diastole and constricts or collapses partially during systole, sorry. So as the blood pressure is going forward, you have collapse. As there's no flow going forward, you have expansion. That collapse and expansion allows for some flow to continue to go forward throughout your entire embolic. Unlike complete stasis, you still do have some antegrade flow. Okay,
so to recap, flow during systole, quote unquote stagnant during diastole. So if you're delivering your embolic, the microvalve, the pressure is high enough to where it can blow past the valve. And so you have nothing but antegrade flow, but nothing should be coming backwards.
Correct. Yeah.
Okay. Just to touch on a little bit of early experience with the Surefire catheter. We were talking a little bit offline for the audience, and we were both, I wouldn't say commiserating, but it's come a long way. It used to have that proprietary SALS catheter, or I think they were all proprietary 5 French catheters that were just very, very stiff. But now, can you use the catheter with any base catheter, any 5 French, 6 French catheter that you want?
For the most part, yes. Some of the larger sizes, you do actually need a larger inner diameter. And that's the whole idea, is that you needed a larger inner diameter than your traditional 038 microcatheter. But I can tell you the newer generations are significantly easier to use. They really took that feedback to heart when redesigning those base catheters. And so now they function almost identically to a normal, sauce. That's my go-to, is I use a sauce.
Okay, same. Okay, let's get into a little bit. As far as the actual catheter, the action point, so you track it, well, actually just kind of go through a procedure, how pressure-directed embolotherapy is the same and different from your standard embolization.
So, the nice part of the way everything is developed now is once you get the microvalve into your base catheter, it functions just like a microcatheter would. It's going to track over a wire just like your microcatheter would. Unlike the older devices, you don't actually get to choose when you want to deploy the valve or not. It's kind of always deployed. It's soft enough that you don't run into spasm. I haven't run into spasm or any issues like that. And so for all intents and purposes, it functions almost identically to a normal microcatheter. Now, it doesn't track nearly as distal, and it's not like your 2.0 Pro grade or Echelon where it's going to, get super distal, but it functions, functionally like a normal microcatheter would.
All right, that's good to know, because I do remember sometimes fussing around with the old catheter, having to deploy the valve, and it's hard to see it. You're like, is it deployed? I think it's deployed. And then I was a fellow, and it was never I was never deploying it properly. I just remember this.
Interestingly, though, angiographically, it will look different. So once you get the microvalve in there, it is reducing the pressure and the flow and everything like that. So it kind of looks like you're not static, but you definitely see sluggish flow as you're infusing a contrast, for instance. And that's normal. I remember the first few times I saw that, I was kind of worried. I'm like, oh man, I'm not going to get any of my drug in there. We're almost already at stasis, when we haven't even started. But that is normal and to be expected. And hopefully I can convince you by the end of this conversation that's actually a good thing.
And does it change, if you're doing power injections, does it change the rate or the volume at which you inject, or nothing like that, all the same?
Nope, everything is exactly the same.
Okay.
I do harp on all my texts to make sure you look at the pressure ratings of all your microcatheters. Some of my texts are just like, oh, it's a microcatheter, it's 750 PSI. But these catheters, at least the TriNav catheters can be up to 1200 PSI, and I recommend using 1200. If you're using a balloon occlusion catheter to get this effect, it is lower, and I do recommend using just whatever the manufacturer's recommended.
Package insert, good advice.
Mm-hmm.
All right, so for your embolic cases, or for your embolic cases, are you using this catheter on every case? Is it for special cases? I guess, what scenarios where this is solving a problem for you?
The big use I found of pressure-directed devices is actually Lobar radioembolization. I think as we'll get into it, the redistribution of flow into the tumors is particularly helpful when you're treating a whole lobe or a whole liver, because you're really thinking not only about tumor dose, but you're thinking about background liver dose. And so anything you can do to augment the background liver dose will be helpful. For Lobar deliveries, there definitely are people out there using balloons. It gets a little cumbersome at that point to get a big enough balloon into a lobar artery. And so for that, I tend to use microvalves just for simplicity.
Okay. So basically, for lobar radioembolization, you think this is a good fit?
I think that's where you're going to get the best benefit, yeah.
Okay. And does it matter what type of tumor you're treating? Does it matter hypervascular versus hypovascular, small versus large, or multifocal versus, I'm just trying to put together a couple scenarios for you to knock them down.
Yeah, of course. Let's start with the easiest, right? So the multifocal bilobar tumors. You're really worried about your background liver, let's say exclusively radioembolization. You are really worried about your background liver dose. So anything you can do to increase your background liver or decrease your background liver dose is going to be super important. And there is compelling basic research and animal translational research to really show that the use of these pressure-directed devices really does affect that number. The T to N ratio, if you listen to our most recent Y90 dosimetry episodes.
Good plug, that's synergy.
Yeah, exactly. So that's the easiest case, because that in my head is just a slam dunk. The next one is big tumors. I think if you're going to get selective and treat big tumors, we were talking earlier about the ischemic core inside of these tumors. Anything you can do to get more deeper into the tumor is going to be effective. And so this is the second case where I would use it, is the big tumors. There, again, is good data, and particularly if you look at the most recent JVIR articles from last year with OncoPig data, they really kind of go into showing this. And I think the images are quite striking, so I recommend all of our viewers to go and look at those papers, particularly the pictures. Jarek et al. Is the first author on 2024 JVIR.
We'll link to it, Zach.
Okay, good. For that, it makes sense too. Big tumors, you need to get penetration into all of the tumor-feeding vessels. That leaves us with the most controversial, and that's the small tumors. And I think we're getting so good with 2 centimeter HCCs, for instance, with ablative radioembolization, that you don't necessarily need to use these catheters and these adjunctive techniques. We have parameters now with dosing and microsphere activity and your microsphere density that we can get 75, 90% rates of complete pathologic necrosis, it's really hard to do a lot better than that. And so I probably would not use these catheters there.
So as far as like the limitations of the catheter though, like let's just say like you did want to treat like a 2 centimeter more distal peripheral HCC, is the catheter, assuming like tractability is not a problem, how small of a vessel can you get into?
So it depends on which device you're using, right?
Okay.
So there's balloon occlusion catheters from the neuro side that can, they're used to going very deep into the brain. So you can get some of those like Scepter very deep into the system and, 1 millimeter vessels, et cetera. If you're starting to talk about microvalves, you need to usually about 1.5 millimeters is kind of what you want. Again, they're just bigger devices compared to our neuro devices, which are smaller and used to going more distal.
So in the 3 scenarios, there's Lobar treatment, multifocal, where you're going to do a Lobar treatment, and then you want to use microvalve. And then big tumors, where you're going to take a more proximal embolization, but you're going to try and hit all the tumor vessels. Is that the scenario that you're describing?
So yeah, let's talk about like a 6 or 7 centimeter tumor being supplied by exclusively segment 8 hepatic artery, right? You're just going to get to the proximal segment 8 hepatic artery because, there's all of the side branches that might be feeding it. And whether you're using an end-hole catheter or a microvalve catheter, you're going to be treating from the same place, if that makes sense. Like a traditional like segmentectomy. We're just taking out the whole like segment 8 tumor. In those scenarios, I would use a pressure-directed catheter, again, because I've drank the Kool-Aid about deeper penetration and some of the other benefits of the microcatheter. And for the sake of simplicity, if it's a very proximal infusion, I just use a microvalve because I don't have to worry about popping a balloon or seeing a balloon or any of the issues you might run into by using a balloon. The frustration is just significantly less. The downside is some of the microvalves can't go as far, but for some of these bigger tumors, a little bit more proximal tumors, I think the microvalve really shines.
Now a good time to show the cases?
All right, so I figured I'd show some cases and hopefully explain how I would use these different types of technologies and I think the benefits. So the first patient's one of my patients with a grade 3 well-differentiated neuroendocrine tumor.
So the metastatic neuroendocrine, what was your plan for this going into it? Like
when I look at these sorts of referrals, my first question is, can I be ablative, right? And so whether that's percutaneous ablation or using ablative radioembolization, that's what I always think because I think that's going to be the best for the patient. Now, as you can see here, multifocal by Lobar, there's innumerable metastases. This is a very common neuroendocrine appearance. So I don't think I can be ablative here. And so the next thing I have to think about is, can I deliver an effective amount of dose, in this case radiation, to the tumors without worrying about damaging the background liver? And so that's my first thought, that this guy's going to be likely staged by Lobar radioembolization.
Got it.
And so that's what we did. As you can see here, we have 2 cone beam CTs from each of the embolizations showing that there are hypervascular tumors. We treated the right lobe first, and then we treated the left lobe second. Relatively similar distributions of the tumors by Lobar. And again, they're quite small. They're taking up very small parts of the liver. And so I ended up treating this using 2 different approaches. So the one on the right, the artery was too big for me to use a microvalve. And so I ended up just using my 2,4 Prograde. And both of these were treated with resin microspheres, 3-day precalibrated. And on the right-hand side, you can see there's a ton of uptake in the background liver. And you do see kind of focal areas of uptake inside of the tumor. But you really do see a decent degree of uptake in the background liver. On the left-hand side, I did end up using a microvalve on this case, and you can see there really is just focal uptake inside of the tumors with very minimal background liver uptake. And both of these were treated with 3-day precalibrated resin microspheres and the same partition dosimetry. So really the only variable I changed here was, I guess, 1 month in time between these and the microvalve that we used. And so this really shows the ability to decrease the background liver uptake. There's no randomized controlled trials that show the benefit of all of this. There are some interesting trials, particularly Pasiak et al., that looked at MAA studies and the difference between an end-hole catheter and a microvalve and showed that not only does the tumor dose go up by 20 to 90%, depending on the patient, but the background liver dose also goes down by a similar amount there as well. So there is some prospective data. Again, no phase 3 randomized trial, but once you see pictures like this, it's pretty convincing that there is something happening here.
Let me ask you this also. So I have a couple of questions about this. How big was the vessel, ballpark, to where you couldn't use the microvalve catheter?
About 6 millimeters.
Okay, 6 millimeters. So what's the upper limit of vessel size to use the microvalve?
So the current iteration of microvalves go up to about 5.5.
My question is, if you used it in a 6 millimeter vessel, is there a downside? Like or it just would be rendered useless? You know what I mean?
So I think that's actually a fantastic question because that allows us to kind of talk about how I think the catheter actually works. All of these catheters, I think, have a series of mechanical effects and then also kind of physiologic vessel effects. And so let's start with the easy one, which is the vessel effects. The first one is it causes turbulence of flow, which mixes the spheres that you're infusing into the artery just at the tip of the catheter. So you can imagine if you have a catheter facing one direction or another, it may preferentially push your microspheres one direction or another. And so, if you're at a vessel bifurcation, and you're facing towards one of the bifurcations, you can imagine a lot of your embolic material going into that one bifurcation versus equally between both. And you want it to go equally between both because then it's just the physiologic resistance of the tumor being less that's going to drive the increased, let's say, radioembolic material into the tumor. The second one is it puts you into the center. You can imagine you have a balloon expanded or you had a microvalve expanded. The tip of your microcatheter is going to be in the center of the vessel. Again, that just leads to allowing homogeneous perfusion into both sides. The third one is the anti-reflux properties of a catheter. And so you can imagine if your microvalve wasn't fully occluding the vessel because it was too big, you may not get the anti-reflux properties. But for the most part, as long as it's not dramatically too big, you're still going to get the homogenizing of the flow and vessel centering properties, if that makes sense, because you're still relatively going to be centered because the microvalve is kind of pushing 5.5 millimeters or the balloon's pushing 5.5 millimeters either side. Now, the interesting part actually comes when you start talking about the physiologic effects. And I think as we're looking at this case, I think the physiologic effects is really where the idea of pressure modulation comes into play. Because all of the first effects that we were talking about is increased pressure. But a lot of the redistribution I actually think comes with decreased pressure. So there's a lot of research, again, a lot of it done by Steve Rose, the guy who mentored me and trained me, showed that when you expand these microvalves, at the tip of your microcatheter, the pressure is significantly decreased. And so this is where it gets a little, you have to imagine this in your head a little bit. But if you have two compartments, you have a high pressure compartment, which is your systemic arteries, and then you have a low pressure compartment, which is everything distal to your occlusion catheter, whether it be a balloon or a microvalve. Everything distal is going to have different physiology. So one of the ways these microcatheters, I think, work is when the hepatic artery has a decreased relative pressure, suddenly the normal arteries are going to constrict because the liver wants a normal blood flow, right? So you can think of your trauma patient, all of the arteries are clamped down, right? Because the body's really trying to maintain perfusion pressures. And so all of the arteries in the liver are clamped down and trying to maintain the pressures that you just dropped. The tumor can't do that, right? We talked about not having the neural components do it earlier. We talked about not having the smooth muscle components do it, right? It can't clamp down. So now you have all of these clamped down arteries in the normal liver vasculature and a relatively similar unclamped down, maximally dilated tumor arteries that are irregular. You have redistribution of the flow, preferentially more towards the tumor. That's one thing that could be happening. The second thing that could be happening now is imagine if you have a tumor in segment 8 and you create a downstream, vascular compartment by, having these catheters in there. You have a drop in pressure. Now you have intrahepatic collaterals from, let's say, segment 4 and segment 7 that are still at systemic arterial pressures because you haven't occluded them. They're going to be pushing into segment 8, right? Because they're going to go from the high pressure to the low pressure, just like water goes from, uphill to downhill. And so you're going to now have redistribution of the intrahepatic collaterals where everything is going to be pushing into your segment that you're going to be treating, again, with the tumor being the least resistive path for the blood flow to go. And so you have decreased pressure, which can modulate how your embolic material, whether it be chemoembolic or radioembolic, gets delivered into the tumors. Now, you're going to say, you're just full of it. That's BS. What evidence do we have for any of this? Like I said, a lot of the stuff was first noticed very early on by the Japanese. Like I said, 1991 is when this was all discovered. And since then, a lot of people have looked into when do we see this redistribution of the flow? And so if you look at the balloon occlusion TACE data, they talk about this concept of a balloon arterial stump pressure, BOASP. And they say that if you get it below 64 millimeters of mercury, that's actually when you see the redistribution of the flow. If you actually don't get it below a threshold, you don't see redistribution. The second piece of evidence is people were looking in the early 2010s of ways of improving this T to end ratio that we were talking about. And a lot of interest was put into a drug called angiotensin II. I'm sure we all have long since forgot about it since our med school days. But the general concept of it in the kidney, at least, was to maintain pressure, where if they had decreased perfusion pressure to the kidney, it would secrete this hormone, which would act as a vasopressor, right, to increase the flow to the kidney. They were doing that for liver tumors, and they were injecting vasopressin into the arteries and seeing, did that actually alter the T to N ratio? And it did. Again, through that same concept. You're injecting something that's going to make normal arteries constrict. The tumor can't do that. You have redistribution of flow. And then if you look at the only randomized control trial that was done with a Surefire device, again, the early generation microvalve, they saw no difference in the randomized arms to a normal catheter and a microvalve catheter. Interestingly, though, because as we were talking about the early device, they had a lot of spasms, every single patient got treated with nitroglycerin. And so a lot of the benefits that you were getting from the vasoconstriction might have been alleviated because they were given the nitroglycerin. So that's how I think all of this works. And I think a lot more research is being done now that we're starting to get a lot of focus into it. But it is a really cool concept that involves physiology just above and beyond an anti-reflux catheter.
So actually, one of the explanations regarding physiology makes a lot of sense. So if you're cutting off or reducing the blood flow to segment 8, then the normal vessels clamp down, but the tumor vessels cannot, and so they're dysregulated, and they're going to then receive more blood flow than the rest of the vessels. I have to back up on is if you decrease blood flow to segment 8, and then all of a sudden collateral flow comes from adjacent segments, I guess what I would be concerned about in the back of my mind is those collateral vasculatures pulling from adjacent segments would then supply the tumor, and that's actually either washing out your drug delivery or reducing the efficacy. Do you know what I mean?
Totally. And you definitely, anyone who's done this has seen that, right? The paradoxical effect where everything seems to go the complete opposite direction of what you wanted. In my experience, I see that more with balloon occlusion catheter, because again, going back to what we were talking about, you completely occlude antegrade flow. Now, again, that's a lie. There's still some antegrade flow through vasa vasorum, but for all intents and purposes, you obliterate all antegrade flow. The microvalve, one of the benefits of it is that you're still having antegrade flow every single systole. Now, have I seen it happen with a microvalve? Of course I have. I'm sure if you do hundreds of these, you see everything. But for the most part, the chance of having that paradoxical effect, I've seen it less with using a microvalve because antegrade flow is being maintained. But you do have to be very cautious of that. And that's why if you are going to use it, I definitely recommend a cone beam CT just to make sure you actually are seeing the physiology that you're expecting. And you're most commonly going to see this in segment 8 and segment 4, kind of the watershed areas of the liver.
Okay, good tip. Let's do some more cases.
All right, next case. And sorry for that diatribe about physiology.
No, that's awesome. I mean, that's I always the assumption is if I'm into it, the audience is into it. And so I don't know. I think the people who tend to listen to BackTable podcasts are the ones who want to geek out on this stuff. So I just assume they're into it.
All right, case 2. This is a guy with hepatocellular carcinoma and tumor in vein. And so as you can see here, you have a contrast-enhanced CT, very heterogeneous tumor in the kind of posterior sector of the right hepatic lobe. And you can see the expansile tumor, the kind of right posterior portal vein pedicle. Here's the angiogram, and you can see on the angiogram the threads and streaks, the kind of classic angiographic appearance of tumor vascular invasion. For these cases, I always start off with a traditional cone beam CT with an end hole catheter. That's what I did. And if you look at the data from Dosisphere, which is the randomized controlled trial looking at patients essentially like this, huge tumors, tumor in vein, and they were randomized to personalized dosimetry versus conventional dosimetry, and they show this huge survival benefit. They only included patients with tumor in vein who had adequate uptake inside the tumor vascular component. So if you didn't have any uptake in the tumor vascular component, you were not put on the trial. And so we did our first cone beam CT. Here you can see that on the left at the end hole catheter. And there's some arteries going to the tumor, but you really don't see that dense enhancement that you would kind of hope to see for the tumor if you were really going to get a significant amount of radioembolic into the material. So at that moment, we swapped it out for a microvalve. And so here you can see we ended up using the larger size because as you can see, the artery is quite large. And we repeated the cone beam CT 5-10 minutes later with the exact same parameters. And now you can see a marked difference in the tumor vascular uptake. And so I've really found it pretty helpful for these tumor where there's the threads and wisp arteries where you really need to get more dose into. I found that pressure-directed embolotherapy really helps with these cases.
So basically you started out your mapping and this is your standard practice, you start out with an in-hole catheter, and if it's, or there's some cases when you know that you're going to go straight to microvalve?
For my mapping procedures, I always start with an end-hole catheter. It helps you get the lay of the land. Sometimes you don't know if there's variant anatomy, and I like to figure things out first. And I just know I'm going to have more flexibility if I do need to go into a weird artery in order to get into it. Yeah.
Okay. What are you mapping with, out of curiosity? What catheter?
2.4 Prograde is my kind of workhorse catheter.
Whenever you decide to go from in-hole to microvalve, are you using like a long exchange wire, or do you just get back into it, or just depends on the vessel that you're in?
It also depends on the fellow I'm working with. No, I generally just take the whole catheter out and put it back in. Again,
right.
for this tumor here, it was just a proximal right hepatic run.
Sure.
So it's pretty easy to get back into.
Okay, gotcha. Okay, got it. All right, let's see the next one.
And so as you can see here on the 1 month follow-up, you can see the initial angiogram with the really dense tumor vascular enhancement. And you can see at 1 month follow-up, now you see the kind of expected bland thrombosis with no longer arterial enhancement inside the tumor, conferring that we got an adequate dose into the portal vein invasion component.
What did you treat here with resin again?
We used glass on this case. I'm 50-50 in my practice.
Okay. And ballpark, do you remember what dose you delivered?
So in general, we try and follow dosisphere. So it's personalized dosimetry, at least 250 grade of the tumor or greater. This is a HCC who has decompensated liver cirrhosis, ALB3. So again, as we were talking about at the dosimetry talk, these are probably patients you wouldn't want to treat with radioembolization. Their liver disease is really more important. And in general, although this is not exclusively the truth, TACE tends to be better than radioembolization for less risk of decompensation. So for ALB3s, we tend to use TACE.
Okay.
And so as you can see here, this guy has a TIPS as well. If you look at the angiogram on the left, it was placed at an outside hospital. We definitely did not place that TIPS.
I thought it was maybe like a DIPS or something.
No, TIPS. But you can see the 37 millimeter-ish tumor kind of in segment 5/8. And you can see we can get very selective. And again, the benefit of using this in TACE is that as you're embolizing, there's a beautiful paper by Johnson et al. In 2016. They were looking at LC beads and embolization, and they looked at the microvasculature throughout this course of embolization and what happens. The interesting part, not that I want to belabor with all of this basic science, but they saw that if you came to angiographic stasis and then transected the tumors and looked through the tumors, these were, I think, in rabbits, 54% of vessels were completely embolized and 46 remained unembolized. Again, talking about deeper penetration and more penetration into these vessels, even though we think it's angiographically static, you may not be getting all of the tumor microvasculature arteries completely full of your embolic material. And so this is one of those areas where I really would use a microvalve or something like that to really fill up those 46% of vessels, or as many of those 46% of vessels that are not being embolized just with traditional end-hole catheters. This is kind of an example of that. So these, again, I love taking the cone beam CTs before and after, and you can see with an end-hole catheter, there's, portions of the tumor that are less enhancing compared to when, in this case, I used a microvalve with more dense and kind of homogeneous filling throughout the entire tumor. And particularly, I like the capsule here. I feel like the capsule is a lot more visualized throughout the tumor. And so you can see that we are really going to get deeper, theoretically deeper penetration and more of our drug into that. And that's been confirmed in studies as well. And if you look at the necrosis afterwards, there's a nice paper by Titano et al. That looked at explant livers, and they showed that the degree of necrosis was quite significantly a bit larger with these microvalve compared to standard end-hole catheters. And as expected, you can see a non-enhancing tumor both on MRI and CT to follow. In this particular case, it was not super distal, right? If you go back a few slides, it was only 1 or 2 turns in order for me to get in there. I wasn't worried about getting super distal. And so in this scenario, I used a microvalve because, again, you have to prep a balloon. You have to make sure the balloon doesn't burst. You have to, there's a lot more that for that goes into a balloon microcatheter, but again, it can get more distal. So I usually start off with an end-hole catheter like we were mentioning earlier, and that allows me to map out exactly what I need to do. And then I can choose my more expensive catheter based on that.
Okay, got it.
And so we were talking earlier about where I would like to use pressure delivery as well. And I think large heterogeneous tumors are very helpful. So in this case, this is a biopsy-proven cholangiocarcinoma. And here you can see this is, areas of necrosis. There's areas of really a high uptake of enhancement, but then there's like the fibrous components that are only filling on a more delayed phases, as you can see on an earlier arterial phase on the left, and then a more delayed phase on the right. And again, it's large, right? Encompassing essentially the entire left lateral segment of the liver. And so we took him for an angiogram. He ended up having a replaced left hepatic artery, or at least segment 2-3 artery And this is, again, going back to, where we started off our conversation today. This is literally where this all started, right? Trying to protect gastric arteries. Now, since then we've realized you get deeper penetration, more homogeneous penetration, but at least this felt like a nice correlator to that, where you're going to protect your gastric branches from your radioembolization. And here you can see a cone beam CT where there's areas of fat inside of it, or necrosis. It's hard for me to tell, that we weren't infusing and they were not enhancing on the MRI. But we are able to get kind of homogeneous and really good enhancement of the entire tumor. And so at 1 month post, you can see here, we were able to get, a very effective and dense radioembolization, where you could argue maybe there's some areas of enhancement. And so whether it's a MRIS's complete response or near a complete response, either way, the patient, clearly benefited by having this degree of necrosis 1 month later. And so I hope there's more data in the future that really solidifies this as a benefit. But in my practice, I've really seen patients benefit from pressure-enabled delivery, particularly for large heterogeneous tumors like this.
Okay. Is there one more?
And so this last case is another Lobar net neuroendocrine tumor patient. A large amount of my practice is neuroendocrine tumor patients, so I'm a little bit biased towards that. And so here you can see this patient has a 6.7 centimeter tumor kind of in the posterior sector. They also had numerous bilobar smaller tumors. So this patient ultimately was going to need staged bilobar therapies. But I'm really going to highlight this larger tumor because I think that the effect was quite dramatic. If you look at my first conventional angiogram, I think you can see it there. It definitely is enhancing. And so we thought we were good to go, just an end hole catheter. So we infused our MAA. And if you go to the next slide, we kind of freaked out because you can see at our MAA, we just had no preferential uptake to the tumor. The uptake was into the background liver. T to N ratio is essentially 1, where we just didn't see anything into that large tumor.
Did you have a cone beam from that prior to the MAA?
Yeah. And it looked essentially like how the MEA looked.
Okay. Got it. Okay.
So I had a sneaking suspicion that was going to be the case. Now they actually have a CPT code that you can use during the mapping procedure to get reimbursed for using like a TriNav, for instance. So I probably in the future would have used it there, but they didn't have a code then, and so I didn't use it. But I knew I was going to use the microvalve when I brought him back, because if nothing happened, whatever. But I know if I can get any increased uptake into the tumor, anything at all is going to help this scenario, right? And so you can see we used a microvalve. We treated from exactly the same position, just a right lobar infusion at the time of Y90. And as you can see here, this is our uptake spec CT from the Y90, where you can see really dense uptake inside of the tumor. This looks identical to the paper that I was referencing earlier, Jarek et al. In JVIR from last year, where you can see when they took oncopigs and used both end-hole microcatheters and the microvalve catheters, they saw similar pictures just like this. So you can call BS all you want. Do I see this every single time? No, but you see this a couple of times, and you're sold that this is clearly going to hopefully benefit patients. Case 6, a segmental HCC. So as you can see here, a large tumor that's likely being supplied by a single segmental, feeding vessel.
Very nice.
And so here you can see on the left is the microvalve cone beam CT, and on the right is an end hole catheter cone beam CT. I particularly want to look at the center of the tumor, and you can see that there's areas of the necrotic portion that we're not, having uptake with the contrast. When we use a pressure generating device, you can see we're able to now perfuse the deeper portions of the tumor. And again, going back to when we were talking about mechanisms of action, there's very different mechanisms of action depending on where you're treating from and what you're treating from, right? So this patient is likely benefiting from the mechanical portions of it, where we're able to increase the pressure, pushing it in from the anti-reflux properties, as well as maybe to some degree the vessel centering and turbulent flow portions of it. Where the Lobar case that we looked at previously was clearly the physiologic, vessel vascular changes. So whenever I'm asked, how do I think these catheters work? It's a very complex question. And I think it's ultimately very multifactorial, with a bunch of different mechanisms kind of all bundled into one that you can use to your benefit depending on which scenario you're trying to think of embolizing with. And then 1 month post, you can see just a nice M-resist complete response with a complete normalization of this patient's AFP.
That's nice. That's pretty.
The grand finale of all my cases, this gentleman was referred to me for radioembolization. He had a gigantic 12 centimeter HCC, if not larger. And I always tell myself, I'm never going to say no just based on an MRI or a CT scan. I'll give every patient the benefit of the doubt and at least do a mapping procedure. And for this gentleman, here you can see a common hepatic artery cone beam CT where I just want to get a lay of the land of the tumor. I was able actually to get selective. I was able to get into a segment 4 feeding vessel that was getting the kind of the left side of the tumor. And then I was able to get into the anterior sector right that was feeding the posterior side of it. And I'm like, oh, okay, he passed this first test. I'm going to get a lung shunt that's 55%. And I'm going to say I can't do this, right? And of course, the lung shunt comes back like 1.5%. And you're like, I feel so glad I gave him the benefit of the doubt. And I saw this size of a tumor and I'm screaming to myself, I'm like, I need spheres, right? I need a lot of microspheres and I really want them to go all throughout the tumor. So I chose resin microspheres. There is a lot to be said about specific activity or microsphere activity, and you want to use a high amount as you can. So I use a very large pre-calibrated date of my resin, but even then I was, large number of spheres. And I segmentally delivered into each of the feeding vessels into the tumor. Again, I wanted the deeper penetration and I wanted less reflux, right? And if I can protect any normal liver, every single cc of normal liver in this case is going to help me make this a safe radioembolization, right? So for him, I was just like, let's throw everything at it. Let's use all of the mechanisms. And I think the next slide hopefully is here's my SPECT from the treatment. And, everyone's high-fiving each other. I looked immediately at the lungs on the SPECT just to make sure that no radiation got there because it was a lot of radiation. And the surgery rep looked at me like I was crazy. Clearly we got it all into the tumor. We can see it's nice homogeneously all throughout the tumor. And if you look at the next slide, this is 2 years later. We have a nice, this guy was in his 80s. He had a single outpatient procedure that we were able to get this response to. So, this kind of last case kind of put everything together of how I think, pressure-enabled delivery can really help patients out.
All right. Very nice. Very nice. I must say. Good cases. All right. So I got a couple of questions and we can try and do them rapid fire or, just however long they take. But I kind of titled this part of the outline like best practices. We talked about like vessel sizing, and can you give like any more detail on like how many, like assuming like the vessel size is not a problem, like when is tortuosity, when can you start thinking that this catheter's either not going to make the next turn or not going to get you in a position where you can be put to embolize? I know that's hard to put into words, but give it a go.
Of course. I think the easiest way to start that question is don't do what I did when I first started using the catheter. And this is like what I tell everyone as they're starting to begin to use the microvalve technology is just choose easy cases. I chose the most tortuous artery I could have ever for my first case. And oh man, it was a painful experience. And I'm like, I'm never doing this again. And again, I was sold on pressure-directed delivery even before I took my case on. I think for your first case, it's always great to do either segmental, like a proximal segmental, or sectoral, or lobar delivery, because I think you're going to have a much easier time. Anything you're going to try and get super distal, if you're used to using like a TriSalus, for instance, you're not going to have that experience. None of these catheters are mimicking that. They just do too much to also be that dynamic, And so don't expect it to be that. And so start off with your, nice, easy wins. It's like what you tell your fellows as soon as they graduate, in your first year of practice, just choose the easy wins, really build up your confidence and your skill set using these types of catheters, and then slowly start to expand it, right? So maybe start off with a Lobar, do a few Lobars, then go to a sectoral, and then you find that one where you're like, I really want to do a nice TACE, and like this guy's really decompensated, but I need to get distal. And then you choose that one for your distal one, and then kind of slowly build up your experience with tips and tricks on how to make these catheters get distal.
I tell you what, the scenario that you described to me that kind of resonated is like I've had plenty of treatments where it's like right at a bifurcation and I park my in-hole catheter, but it just seems like the in-hole catheter wants to preferentially go towards the artery that I'm a little less interested in, or it's an artery that I want to treat, but I don't want 90% going in one. And so I'm always like, oh, I sure hope on the day of treatment it's either angled just slightly, because it just feels like that, like when you mentioned like the catheter like kind of centers itself, and then hopefully like the drug is like more evenly distributed between two branches. Base catheter considerations: use it with a Cobra, use it with a sauce, using like when do you have to change your base catheter, or any base catheter recommendations?
Yeah, of course. So I use a sauce for simplicity, that all my cases start with a sauce. I really like the reverse curve catheter of it, and I like that it's self-forming. So I always start with a sauce catheter. If I'm using the larger TriNav version of it, they have a sauce shape, and I'll just use that. So it's exactly the same shape as the sauce. If I need more purchase, I would probably switch over to like a Sim 1 or to really, I really just like reverse curves. And I know one of my partners and the person who trained me, Isabella Newton, always makes fun of me because she's like a cobra out in the hepatic artery. And she always makes fun of my skills that I always am too nervous to do that. And I just use my little reverse curve catheters just in the celiac artery. But yeah, I think all of those have their benefits. And I just use a sauce because it's self-forming.
Okay. And as far as the lengths of your 5-French catheters, 65, 80 centimeters is going to be fine.
I do femoral for most of my cases unless there's a reason to come radial for me. I just ergonomically, I've never figured out how to set up a room for radial. And I know others have figured it out. And, hopefully as we start building more of our new angio suites, we can make radial a little bit easier. But at least for me, ergonomically, femoral seems to work best. So I work in the 60, 65 range with 110 to 130 microcatheters.
Do they go 150 if you need them?
They do.
Okay. Can all embolics go through it? There's nothing that's off limit. Liquid embolics, resin, glass, Lipiodol, whatever.
Yeah, resin, glass, they all have the 020 inner diameter, and you're totally fine with both of those. Conventional TACE with Lipiodol, use it all the time, and I've never run into issues.
Okay. Can you coil through it if you need to? I don't know if that ever comes up, but...
Yes. The inner diameter is fine. I can't say I've ever tried because, again, I usually start with the end hole and I'll do all my coiling first. Although, to be honest with you, I the amount of coiling cases that I do these days is pretty close to zero.
You already mentioned contrast dosing or contrast volumes and flow rates are the same. You did mention change your pressure.
You have to change your pressure.
Okay.
I do that with all of my microcatheters. I think we, are a little complacent, we being all of us, where it's just like base catheter 600, microcatheter 750. And it's like in big black letters on every single catheter that you open what the pressure limit is. And since I've started using what they, the manufacturers have actually recommend you use, I get so much better pictures. And it's like a novel concept, right? Just do what the manufacturers ask you to do.
All right. That's a good tip. All right. So downsides or which cases to avoid. One of the things I was going to throw out was cost of these catheters. I mean, there must be an added cost to it. And you mentioned earlier a code. Is there a pass-through for the microvalve?
Yeah. So let's talk about downsides technically first. They don't go nearly as distal. They are not your 2.0, prograde. They're not your true select. So if you really do feel like you need to get that distal in order to safely deliver whatever you're trying to deliver, you may have a little bit of struggle. But for most cases, you can get these catheters exactly where you need to get them. And, all of these companies are manufacturing better catheters day by day. So when you listen to this podcast 7 years from now, you may be like, Berman's full of, crap.
Is there a world where someone's going to listen to this 7 years from now?
It actually is, because today, I listened to your very first podcasts where you talked about this exact concept. It was podcast 16 and podcast 20. And those were both 17 and 2018.
All right. Fair statement.
So
there's a world.
And I highly recommend anyone who's in the space go back and listen to those. It's a time capsule. There were some great debates in it that are just not happening at all today. And so I have a feeling I'm going to have egg on my face in 7 years. But and so let's talk about cost, right? And so this is a tricky, like healthcare economics are tricky. These are expensive catheters, right? Now, the ultimate question is, if you do one of these procedures, but you prevent a second procedure from needing to be done, right? You do one TACE with a microvalve. Now you don't need to do your second, third, fourth, or fifth TACE. All of a sudden that catheter now seems a lot cheaper, right? And then the second one is if the patient goes on to get a transplant and they have no recurrence afterwards, now, they're not going to be on systemic therapy. And so people much smarter than me, although we were talking about my college education earlier, I technically have a degree in economics, but you don't want me doing that math, are going to have to figure that out, right? The actual healthcare economics. What we do know, though, is that Congress actually passed a law, which is fascinating in this environment, that they all agreed on a concept to generate the CPT code, which is C9797, which is the code that you use when you're using the microvalve catheter, the TriNav, that you do get reimbursed for it. You're going to look at all the money that code generates, and we went back and looked at all of our cases. You're not going to make a ton of money using the catheters, but you're not going to lose money. You're not going to lose money using these expensive catheters either. So you're going to pretty much break exactly where you were with an end hole catheter use by using these catheters. So, at least for me, you're not losing money. And so for me, that was a win in and of itself locally. And then if you can prevent one additional procedure down the line, you're now probably benefiting society and like Medicare, the group pool of money, by preventing that. But I think that's an area that we definitely need more, modeling and data to be generated.
One thing that just entered my brain, a question that I didn't ask, and it's a little bit maybe not so important, but I do want to ask real quick. The wire that you use with the catheters, just so people know.
I use a 0.014 fathom, and I highly recommend that particular wire. People go look at the manufacturing of and see what else is made on the manufacturing line.
All right, last question or last kind of topic, future of pressure-directed embolotherapy. Where do you see it? Where do you hope it goes?
Yeah, so I think better understanding how it's affecting radioembolization, I think we need more data in that space because that's going to bring it to today. I think extrahepatic indications, I think we need to figure out who's going to benefit from it. Again, as we were talking about prostate artery embolization, I think that's intriguing, but I'm not a prostate guy, so you'd have to go ask some of them. Uterine artery embolization is what people are looking at, thyroid embolization. There was a very fascinating paper. It was a phase 1 study out of MGH, I think, looking at bronchial artery radioembolization. They did a mapping procedure for patients with like multifocal tumors bisect. And they saw a T to N ratio of 26. And I'm like, oh my God, we need to get radiation in there, right? That's like screaming for a procedure to be developed. So that would be one future indication too, where, the higher you can drive the T to N ratio, the less radiation you actually need in order to get an effective biologic equivalent dose.
All right. Any questions that I didn't ask, Zach? Anything?
I think what's also unique is that we're starting to see more and more indications outside of just our normal chemoembolization and radioembolization. I've become particularly fascinated with drug delivery. And so we have a clinical trial open right now where we're actually using the TriNav device and the drug that the company makes, nelitolimod, which is a TLR9 agonist, to treat HCC. And there's some interesting trials that came out looking at ocular melanoma as well as HCC and cholangio with both intrahepatic delivery of immunotherapy and systemic immunotherapy. And then I think we're going to start to see a lot more of this drug delivery coming out where more and more trials look at, intraarterial gemcitabine for pancreatic cancer, et cetera. So I think the future is very bright, and especially as we start to figure out how we can get more higher concentrations of drug very locally that you can't get physiologically, I think we're going to see, a huge benefit. And I think pressure is one of the ways we could do that.
All right, I think that's a good place to put a pin in it. Zach, thank you again for coming on the show. To our audience, thank you for listening. We'll see you next time on the BackTable Podcast. Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.